If an irritation of a blood vessel can cause hemifacial issues, could the same issue be responsible for benign essential blepharospasm? It's a good question. I think you would expect that downstream problems with eye closure or the facial nerve in general would stand to reason then if it affected the whole face, like in blepharospasm, could it be peripheral? However, the likelihood of that occurring is very low. You can imagine that in a certain individual there might be bilateral irritation, and so you would have a previous bilateral facial palsy or two blood vessels in the wrong place. But I think that the data for the vast majority of our patients who truly have essential blepharospasm is that the generators are between the combinations of the thinking part of the brain, the cortex, the basal ganglia, the pons and the cerebellum, and then some secondary downstream effect on the blink reflex coming out of the brainstem. So likelihood is very low that you would have two blood vessels in two different places causing a syndrome that looks like blepharospasm, but it's probably been published that there is a case or two of somebody out there.
And it was published. There was a researcher in Pittsburgh who believed that there's a researcher in Pittsburgh who believed that when that cervical dystonia could be caused by a blood vessel problem. So he would do a decompression of blood vessels in the lower part of the brainstem and high cervical cord, and reported tremendous results. We were able to gather a group of people around to examine those patients, and they were no better. So it's not a procedure to pursue.
This is at least the third or fourth question about inherited blepharospasm. I had a couple others about children of people with blepharospasm having a higher risk. And this question is on the same vein. My children are concerned about getting blepharospasm. What are their chances? I'm the first and only family member. As far as we understand it with blepharospasm, it's typically not inherited. So I would consider their risk the same as anybody else walking on the street. Just because you have it might not mean that they're going to get it.
And I would agree with that. I don't want to jump on your question because I agree with it completely, but I want you to just know that the old guy thinks the same thing too. And I don't want you to be worried about it. Your family's very worried about it, and it's important for you to communicate, no, this is mine, not yours.
I feel obligated to agree also.
Yeah, the hand raised up.
I was just wondering, with that, are there any environmental toxins that may be related, and then, of course, family would be all exposed potentially?
So that's been looked at a lot. We know that facial trauma can sometimes increase that risk, but when that was part of the reason that Dr. Mahant and Dr. Peckham began to look at all of these risk factors, and nothing bubbled out from it. So a toxin exposure, I don't think can happen. That can cause that. Now it was thought that with facial trauma, maybe you had some corneal trauma. So the cornea, the eyeball, the front of the eyeball that you look through, and so maybe if you had a chemical burn, that could happen, but it was never borne out.
I've got another question here. Why can I look down at the floor, reading books, etc., but I have trouble looking straight ahead, especially with any movement, such as in a movie or driving in a car? Is that from blepharospasm, or is that more of a visual impairment, which is unrelated? Well, if it's visual impairment, then that's essentially what your syndrome would be, is if you're looking downward up close, some patients can see some blurry vision or some even mild double vision from something called convergence insufficiency. So when we look down at something easy, the eyes come together, and if you look at a distance, and if that's where your trouble is at a distance, you can also see divergence insufficiency. And that's not uniquely related to blepharospasm at all. That's more common as we get older, and it can be seen in some other conditions also. And then, as you also suggest, if you're looking at a distance, you might just be nearsighted versus farsighted. However, there is also that sensory input loop, the checks and balances section where we talked about the genesis of blepharospasm. And so for some patients, there is a positional nature to the lids and to the eyes that can be more comfortable or less comfortable, or more likely or less likely to generate the spasm. And so for this individual, if there was easier to look down but more difficulty with looking ahead, it may actually be the natural position of the lids over the eyes that will either inhibit or facilitate a normal or abnormal movement. Any other comments?
I have one. So this is a preface a person has written. Personally, I saw 30 doctors before I was diagnosed. I think she's or whoever wrote this is fairly understated. She writes, very frustrating. Would love to help raise awareness. How can patients help spread the word about blepharospasm to optometrists and ophthalmologists? 30 is a high number of people to see before you're diagnosed. I think before the Wall Street Journal paper, the average number of doctors patients saw before diagnosis was 9, and it's much lower since then. But I think we have to keep spreading the word. Unfortunately, when you are desperately seeking a diagnosis and you don't know your diagnosis, you can't spread the word. I don't think it's a good strategy to write a letter to those 29 physicians. I don't think that would really be helpful. But I would tell you that when I train fellows and patients come in with a lot of symptoms, the drama scares my fellows, and they lose track of the fact that you really are sick, that something's wrong with you. All they sense is, I don't know what's wrong with them. I don't know what I'm going to tell this person. And so they run out. I calm them down, and we talk through, and then we begin to work through these issues. And it's important for the fellow to realize, all right, if I'm all aflutter, I cannot do my job, and people are paying me to do a job. And so the only thing you can really do, I think, is try to calm your doctor down. And that, I didn't mean for that to be that funny. I think
Clonazepam works.
If you come in to see a doctor, you have to use that doctor as an effective tool to help you. And if you scare the doctor, you're not using that effectively. And so you have to really work to say, well, I saw somebody today who talked about all of these symptoms that she had, and she clearly has dystonia, but she scared her doctors. And they were really good doctors, friends of mine, good friends of mine. And so you have to say, you know what, I know I have a neck problem, I know I have eye problems, and I know I have a writer's cramp, but if you could just help me with my eyes a little bit, I would be so grateful. You give a doctor a chance to help you without all the panic, and that may be a strategy for you to use. The comment is we're frustrated. I agree with you. I think that sometimes you have to treat doctors like your children. And when I take care, so I take care of 8,000 clinical research projects, and all those doctors are like my son when he was 7. My son, when he was 7, wanted to do exactly what he wanted to do, and he wanted me to be really happy about it. And so that's who you're dealing with.
Well, just to put a phrase to it or a face to it, what he means or what we mean, don't scare your doctor, is you can imagine, probably in any field that you are, if somebody walks in and goes, well, I've seen 30 of your type, what can you do for me? Your first impulse is, well, probably nothing, have a good day. So that's what we mean, just give a little. I think I would ask that you do maybe not write a letter to all the 30, but I certainly appreciate it hearing some feedback on somebody who's gotten a second opinion, and that second opinion doctor sent their note back to me. And it was, oh, aha, that's what it was. So then from then on, I don't need to send that another patient for a second opinion. I know what it is. So maybe not all 30, but once you do find the doctor that diagnoses you ask them to send their report back to the one you saw before. I think it's extremely helpful.
29 cc's would be a lot for one letter. Yeah.
Is this not taught in medical school at all? Anything? I mean, I know there must be something about the eye, but is this?
The question is this not taught in medical school? So the best way to describe medical school is like you're learning the United States, every city in the United States, and how they're related to each other. And you can only carry that information for about 30 minutes, and then you have to start weaning out information so that a year or 2 years later, you only know the big cities. And then a few years later, you only know a couple of cities near you. So you can't retain all that information. And for some doctors, it might be years before they ever saw a patient with blepharospasm. And so when that person walks in their door, they might not recognize it. So 30 years ago, they learned about it in med school, but they haven't seen it or didn't recognize it until one day. So yeah, it's a lot of information to retain.
I think it also speaks a little bit to the supply and demand problems that Mark was talking about also in not only the movement disorder world, but even neurology in general. So I'm sure a lot of you in your communities recognize that if you need to see a cardiologist, you could probably get an appointment in a couple of weeks, but if you need to see a neurologist, maybe just a general neurologist, they're going to tell you that they'll see you over Thanksgiving. And that's a real problem for this country, and we're all involved with medical education, neurologic education, and then the higher level of education of fellows. And so we appreciate it up here. You appreciate it there. But there's just a shortage right now. And I think it's a problem with an aging patient population and with fewer people entering the field of neurology. The gap is unfortunately widening probably before it's going to narrow. So these types of symposia, the work that you can do from a grassroots perspective to continue to educate your physicians, your neurologists, your primary care doctors, who it's their job to decide whether to send someone to see a neurologist or an ophthalmologist or both. I think it's really emphasizes the important work that the foundation does.
Excuse me, to that end, is it possible that you can see a neuro-ophthalmologist and they can dispense the same type of treatment as a neurologist?
So the question is, will a neuro-ophthalmologist dispense the same kind of treatment? And the answer, for the most part, is yes. Sometimes even that depends a little bit on the angle of training. A neuro-ophthalmologist can become that either through a base training in ophthalmology, where they do a lot of eye surgeries and learn the eye, and then do fellowship training in neuro-ophthalmology, or neurology followed by neuro-ophthalmology. And I'm probably a little biased, but I would argue that sometimes the neurologists who go into neuro-ophthalmology are more comfortable with a wider types of the movement disorders as well as other types of neuro-ophthalmological problems. But as a rule, yes, a good neuro-ophthalmologist, this might be in their bread and butter as well. Do you know, are there neuro-ophthalmologists in your neighborhood that will actually do Botox injections?
We have a neurology-trained neuro-ophthalmologist who doesn't do a lot of injection, but he can. The ophthalmologist who specializes in neuro-ophthalmology can do injections and surgery. And so the only thing I would be worried about is if they inject and give up too quickly, or they don't inject very well because they want to get to the surgery, because they get paid for surgery. And so I always try to be careful with that. It was nice, it was refreshing to hear, yes, we try to inject, we try to look at patients and look at all options, but if you come from overseas for surgery, you're probably going to get surgery. I know that Dr. Anderson used to always inject his patients with botulinum toxin first before he operated on them if they were coming from the United States. And I think that's very responsible, because if you don't need all of your eye muscle taken out of your eye because you just need somebody competent in injecting you, it's better to find the competence in injecting you. And so I know of two patients that he sent to me that were being cared for in other places in North Carolina after they went to have the surgery, and he injected them, they did fine, and said, you just need to go see him. So I think you have to be really careful in decisions about, my mother has a statement, there's no minor surgery if it's on me, and this is not minor surgery.
Yes, sir?
Yes, I want to know, Dr. Stacy, is there any research going on nationwide that you can bring us up to date on that could maybe looking at finding a cure for this condition, like the NIH or any other national organization? Because as I recall, we partnered a couple of years ago with the Dystonia Association advocacy group, and we got them funded. So what's going on with that?
So I was hoping you would not notice that I didn't talk about any of that. But that's part of my frustration, and it has to be much more frustrating for you. It's your money, it's your eyes. And I think we have not, coming to join an organization when you bring a high knowledge base, but they have the high patient base, and they have much more funding. They seem to have a larger influence. One of my concerns about the future of blepharospasm's influence is Dr. Hallett may decide he's not going to work till he's 1,000. And Dr. Hallett, if you look at a lot of those grants, they were Dr. Hallett's fellows and trainees. And so I think Dr. Hallett has been effective at moving the dialogue forward where we're included, but we now have to be more forceful about our expectations. And so I would tell you that the work on THAP1, which is a gene, you may have talked about that.
I did, yeah, it was the DYT6.
Yeah, so that work is part of this consortium, but in terms of specifics for finding a cure for any dystonia, we have failed miserably in doing that. We don't understand why dystonia happens yet.
I have a question here that I think I know the answer to, but I'll be interested to see if there is any other opinions. Are there parts of the world where blepharospasm incidence is greater than others? And I think not, but I don't know if there are pockets, if there's been cluster analyses or geocoding that have shown high or low blepharospasm incidence. So it looks like it is ubiquitous, and there's not one place at greater or lesser risk.
And I'm trying to look up the answer to my question.
I should have stalled longer.
The question is, at the Silver Spring Conference several years ago, a presenter mentioned the testing of some high-end cosmetics that gave some results, same as low-dose Botox, which helped blepharospasm, or which may have helped blepharospasm patients. And I didn't, oh, good.
It's acetohexachloride 8, which is known as AH8, and it was found in very high-end wrinkle creams, and they thought that if they used it alone, not in the wrinkle cream, it would help, and they did a double-blind study. I was part of phase 1. Unfortunately, I got the placebo. They were in phase 2. In phase 1, they had people who who were getting their
I really don't know anything about the compound, but I would tell you, we heard you. I didn't really know a lot about this compound or anything about this compound, but I would first tell you that it isn't necessarily unfortunate that you were in the placebo group. If the patients who were in the active group had some sort of trauma from that cream, you would have been glad to be in the placebo group. And so I think it's important for everybody to participate in trials that are answering a question. And the question is, can I get better? The question is, when a research trial, is this treatment effective? And so in this study, I'm not quite sure that they really moved to a scientific level of inquiry with this. I think they were pursuing whether they could convert a cosmetic into a medicine, because then insurers have to pay for it. And they may have figured out that it was going to be too expensive for them to do that. But there's no way they would be able to discuss efficacy from a phase 1 trial. A phase 1 trial is safety. And so if they are implicating, they saw efficacy there, they don't understand what a phase 1 trial would be about. So it's hard for me to kill this idea completely, but I don't like nuanced information or embellished information to try to get you to buy expensive creams. And I think that we have too many corporations who try to prey on the desperate fears of people with blepharospasm or with Parkinson's disease, and that's what this sounds like to me. So I heard it's done at the NIH. It still doesn't make me think that it's going to be that much safer.
It wasn't a phase 1. It was a much smaller test to get a starting idea of whether it might be worthwhile going to later stages. And the idea was they got enough possible positive to see if they should try further testing beyond that first test, and that's what they were recruiting for. But in formal clinical trial terms, there was not phase 1, phase 2.
So I think that the best way to get that question answered is to have the newsletter, have Dr. Howlett from the NIH address this question, and I think that'd be the best way to get it done.
Are there any last-minute burning questions? Uh-oh.
How do you explain the physiology with blepharospasms? Okay. I want to know how you explain the physiology in blepharospasms where you can do certain things and your eyes are wide open, such as singing or public speaking, where in a conversation where you're just listening to people, you're like squinting and blinking, and yet when you have to say something, which I do often, I'm a little elementary teacher, my eyes are open. When I sing in a choir, my eyes are open. What goes on in my brain to make that happen?
Yeah, I think it's mostly those feedback loops. It's the equivalent of the sensory pathways. And by sensory, I don't mean the way necessarily things would feel like to touch or temperature, but rather positioning of the body. We know that both the motor and sensory portions of the brain, as we saw in that homunculus, is close together. We know that there are these feedback loops that stretch throughout the basal ganglia and the brainstem and the pons. And so whether it be the patient that has difficulty looking downward but can look at a distance, or vice versa, or singing but not speaking, or vice versa, for that individual, it seems to be one of the better modulators of their blepharospasm. And it's why when I ask my patients with new diagnoses of blepharospasm about their sensory tricks, I sort of leave it very open initially. I don't say, is it better if you do this or this or this, or the standard ones. We go through those eventually because we know there's historical evidence that it helps for many people. But I say, tell me when you're your best. And then we try to put together and almost create a sensory trick for them based on when they're their best.
Yeah, there was a...
Is it the singer, he was a stutterer, but he didn't stutter when he sang, that kind of stuff? Is that...
So that's a basal ganglia disorder, and so if you think about Parkinson's disease, Parkinson's patients with increasing time, increasing symptoms, they develop a symptom called freezing. And it's because the motor program that they have stored in their cerebellum is not being able to be accessed through the basal ganglia. And you remember the slide I showed, it showed some cerebellar involvement for dystonia. It may be that you are able to access a motor program better when you're doing something else. And so, but I think with a singer who has a stuttering problem, singing is a different motor program than speech, and a song is very predictable. There's a rhythm to it, and you know the words, and so you know what's coming, where if you're inventing speech in the course of a normal conversation, there's a lot of start and stop and a lot of thought.
That was a motor program, and then he also mentioned the sensory input. And I had a question on my desk about a patient that has, whenever they're congested, their blepharospasm is worse. Whenever they're nice and opened up, it's better. And I think, again, that goes back to the whole sensory feedback loop. Yes, ma'am.
In relation to the last question, as a newcomer to all of this, it just sounds like there's an adrenaline component of some sort where startle response and my friend makes it better, or doing something that may cause mild anxiety like public speaking or something that requires more attention. And with that, just wondering if there's been research looking at ephedrine and other things that might be useful for people with this.
So I think we were just chatting. So there is been a little bit of research on the stimulants. Dr. Rao had mentioned the work with Ritalin and others to sort of see whether or not if we can change that balance, like I had on my slide, where I think of it as two gates. So you've got that one gate that's trying to facilitate wanted behavior, and you've got that other gate that's trying to close off unwanted behaviors. And those are based on some things like adrenaline. Actually, dopamine is what's most involved in there. Dopamine both as a stimulating chemical as well as a blocking chemical. And so whether it be amphetamine-like drugs or whether it be just the idea of being awake and alert and interested in something, along with squirting adrenaline, that also squirts dopamine. And it may be on a neurochemical basis that we're able to modulate some of that gating, and so that you can restore the imbalance to back to an ordinary balance. It's kind of a clunky analogy, but I think it works, at least for me.
There are a lot of things that in neurology, though, that get better with an adrenaline surge, so to speak, but it's short-lived, and just to be giving you adrenaline all day long every day would wreak some havoc on the rest of your organs. So my favorite example, if y'all don't know about the New Orleans Saints, but we won a few years back, and for about 2 hours after that final bowl game, there were a bunch of my patients that thought they were cured. It's the adrenaline, but yeah, unfortunately it wears off.
So if you're in misery for like 30 years and you win a game, you get 2 hours of benefit.
That's exactly right. Okay, anything else? Oh, one more.
Yes, if you have blepharospasm, and you get your injections, everything's going fine, and then you have another problem and you take a muscle relaxant, in particular Flexeril. Do you have any information that would cause a problem?
I don't think it's going to be problematic in the sense, but it depends on where you are in the cycle. So in a positive sense, sometimes we will encourage or prescribe patients to use muscle relaxants towards the end of their injection pattern, almost like a bridge. So you recognize that, I call it the toxins rule of threes. It usually works within 3 days to 3 weeks and lasts for 3 months. But for some patients, they might get 2.5 months. And rather than run some of the other risks of doing the injections in closer sequence, every 6 to 8 weeks, for instance, where you might drive antibody production and render the toxin less effective, sometimes I usually don't use Flexeril, but some of the other muscle relaxant or oral drugs as an add-on for that tail. I suppose the flip has been seen in a handful of my patients that they get the toxin done and it's been an effective injection, and if they were taking muscle relaxants, they'll feel a little bit overly relaxed, but I don't know that usually gets in the way of their quality of life.
Flexeril is many times not very well tolerated, so it really won't have anything to do with your eye injections, but you just may not feel well on it, may feel sleepy.
Well, I had it done. I took one on Monday night, and I just had my eyes and Dr. Burns do my talks the 20th this month. And I took one at night, and I woke up the next morning and this eye was almost closed. So he thought maybe that was the cause, because I hadn't had any problems for about 2 years now with my eyes closing.
So I hate when I make somebody's eyelid droop, but it's always my fault. And I do it a lot. I'm not poking funds, but I think that's, you don't need, I don't think so.